Good afternoon, everyone. Welcome to the third webinar of our four-part series on Rheumatology Revealed, updates on common diseases and referral tips for family physicians, hosted by our Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher. I'm the Associate Dean of the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. I'd like to acknowledge that the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nihao, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, 8, and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I myself am a colonial settler. I moved here to Alberta in 2009 from Nova Scotia originally. I just put a link on here for the CMA link to the apology to Indigenous people. And I think I just really want to highlight that in the work that we do together around reconciliation. It's a very powerful meeting. If people haven't had a chance to watch it, I encourage you to have a look at it. Now I'd like to just share a little bit of housekeeping for our webinar today. Just to remind you, if you have any questions, I'd like you to use the Q&A feature at the bottom of the screen. The chat feature is if you have questions about technical difficulties or L3 programs of services that you need to have addressed. For the Q&A, please upvote any questions that you'd really like to have answered. We cannot guarantee that Dr. Sholter will be able to respond to all of your questions, so make sure to upvote the ones you really want to have answered. Just a reminder that the recording of the webinar and the PEARLS document will be sent to everyone who registered in about a week's time. The one from last week just went out today. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Planning tool. And so if you see this QR code or you go to our Lifelong Learning website, you can get access to this free tool. This is great because it does support the PPIP activities for the college, the CPSA. The activity has not been formally reviewed by the CFPC or Royal College, but those of you who are Main Pro Plus participants may also earn additional certified credits by completing a linking learning exercise in the Main Pro Plus platform. So today we are very pleased to welcome Dr. Dale Sholter. Dr. Sholter is going to share with us some insights on diagnosis, current treatment approaches, polymyalgia rheumatica, and tips on referral strategies for family physicians. Dr. Sholter, or as I know him best, Dear Dr. Sholter, is a community-based rheumatologist in Edmonton and a clinical professor in the Department of Medicine at the University of Alberta. He's graduated from the University of Saskatchewan College of Medicine and completed his residencies in both internal medicine and then rheumatology here at the U of A. He's been active for many years. He conducted outreach clinics in Yellowknife, Northwest Territories every 3 months for the last 22 years before retiring from that practice in 2019. And he's been a principal investigator in numerous clinical studies, primarily in the rheumatoid and psoriatic arthritis. He enjoys teaching, medical students, residents, now CPD, and is a long-standing member of the residency program committee here at the U of A. And his clinical interest is in innovative therapies for inflammatory disease. So thanks everybody so much for the great response to these webinars. And I know not everybody can necessarily join, so some of you will be doing this asynchronously. And just like to welcome everybody here to the event today. So Dr. Sholter, you can take it away. I'm gonna mute myself, off my video.
Thanks, Denise, for that really kind introduction. And it's my pleasure to be here. I've always enjoyed teaching, and I've done many talks to family docs, but it seems like it's been a few years. So it's great to be back. And I also am quite pleased with the response to this this kind of seminar series and interest in rheumatology. So what I hope to do is provide you guys with some tips that you can take to clinic starting at 1 o'clock this afternoon, and and take forward in the next coming years as you see these rheumatic disease patients. So anyway, I'm going to try to share my slides here. We'll just go work on that. Okay, here we go. All right. So so the topic that I was asked to do is polymyalgia rheumatica, and it's a really interesting disease, and I'm sure that most of you in practice will have come across these patients before. I just wanted to, before we get started, my disclosures. I've given a lot of pharmaceutical talks, but and some consulting, but I don't think there's anything that's going to be relevant to today's presentation. So my hope at the end of today's presentation is to be able to consider the diagnosis of polymyalgia rheumatica in patients with new onset proximal limb pain, know who is appropriate to refer, and discover tips on how to access rheumatology, which I know from my own experience in accessing other specialists, it can be a challenge these days. And also to explore the challenges of the current treatment approach and gain an understanding of potential future therapeutics. So I thought we'd start off with a case. So this is a lady that I'm actually seeing right at the moment, but she was actually diagnosed with PMR back in 2011. She had a very classic history of proximal limb pain, although she didn't really have terribly high inflammatory markers, but nonetheless, she did very well to a standard approach of low-dose prednisone. But as you will see, not uncommonly, we found it difficult to taper her prednisone, and she couldn't get below about 6 milligrams per day. And then she would self-dose with higher doses. And I find that some people just really like prednisone, and once they get their hands on it, they feel better with more and they take more. And sometimes it can be hard to regulate that piece. But nonetheless, she had trouble tapering, and we added in hydroxychloroquine as a steroid-sparing type of drug, but she had some side effects from that. We offered her methotrexate. She didn't want to take it, and so she was lost to follow-up. And so when I last saw her, she was actually on a fairly high-ish dose of prednisone, 12 milligrams per day. So fast forward to 2022, and she was referred back, and to my horror, she was on 25 milligrams of prednisone and had been on quite a high dose for that whole period of time. But she said, well, you know, a lot of times I'm on a lower dose, but never below 17. She didn't have any symptoms of vasculitis, so giant cell arteritis or temporal arteritis, so which was good. But as you can imagine, she developed a number of steroid related side effects, including osteoporosis. She had had vertebral compression fractures, and she had developed type 2 diabetes. When I examined her, she had a high BMI, but her musculoskeletal examination was actually normal. She abducted her shoulders without pain, and she had no peripheral joint synovitis. So she had, but she was on a big whopping dose of prednisone. So at that point, I ended up offering her methotrexate. She was agreeable to take it, but she was intolerant, of course, with side effects. Couldn't take a really big dose either of methotrexate. She had tapered down her prednisone by 4 milligrams, but still on an unacceptably high dose. So when I think about a patient like that, I always have to circle back and say, hey, is the diagnosis correct, right? If it is correct, why can't we taper the prednisone? And then thirdly, is there or are there other treatments beyond prednisone that can be successful for this condition? So we'll come back to the case at the end, but I thought I'd start off with a polling question, and I've got a few of these scattered throughout. So Andrea's going to pop up a poll here, and so if you guys want to just vote, and then we'll present, we'll just take about 20 seconds and vote. I can read it for you though. So what is PMR? Is number one, is it an autoimmune inflammatory muscle disease, myopathy or myositis? Number 2, an inflammatory arthritis that commonly affects the shoulders and hips. Number 3, a functional disorder associated with non-restorative sleep and muscle tender points. And number 4, a vasculitis, primarily of large vessels. So go ahead and vote. All right. An autoimmune inflammatory muscle disease wins, and that's at 6. I'm just going to write this down for later. Inflammatory arthritis, we said 37%. Okay. And the last two, nobody thinks it's a vasculitis or very rare functional disorder. Okay, we're going to get back to the right answer later. Okay, so how common is this disease? So first of all, when it comes to PMR, we know it's a disease of older individuals, and it increases with age. We really don't see it less than age 50. So if I get a referral, query PMR, and the person's 32, it's probably not PMR. Not to say there's nothing else wrong with that person, but it's likely not PMR. It's not rare. It's the most common inflammatory disease other than rheumatoid arthritis at this age. Most are women, and the trigger is unknown. Okay, so, but like many rheumatic diseases, there's genetics at play. There's certain genes that have been associated with PMR, and they tend to interact with some trigger in the environment. But unfortunately, we don't really know what that trigger is. I mean, I've seen it. There's been some papers published with various types of bacterial type triggers, viral infections, seasonal. I've had patients that have gotten seemingly PMR type symptoms after vaccinations, et cetera. So trigger is really unknown. It's not consistent across the board. But we do know there's definitely some geographic and ethnic predominance. Although it's present in all races all around the world, by far it's more common in Caucasians of Northern European descent. Places like Norway have the highest rates in the world. And with immigration to the US, places like North Dakota and Minnesota, where there's lots of Scandinavians, typically have a fairly high predominance of PMR as well. So second polling question. Which of the following is not a clinical feature of PMR? Number 1, proximal limb pain and stiffness. Number 2, prolonged morning stiffness. Number 3, hand synovitis. And 4, ankle effusions. So go ahead and vote. And the results, which is not. Good job, you guys got that one right. So ankle effusions is not a clinical feature of PMR. So universally, number 1, yes, proximal limb pain and stiffness, by definition, and judging from my objectives, that would be a feature. Number 2, yeah, most, if not all patients will have some degree of morning stiffness. And the 3 and 4, they're tricky, right? So hand synovitis, is that a feature of PMR? And actually it is, okay? And we'll talk about that again in a sec. But ankle effusions, the ankles and feet are not involved in PMR. So that's the incorrect answer, or the correct answer, that's not a feature. All right, so moving on, what are the clinical features? So my little man there, you can see the shaded areas. That's typically the sites of pain. So shoulder girdle region, neck, hip girdle region, your anterior, posterior thighs. So the onset is typically subacute or acute. I've seen both cases. I've seen people literally wake up with it over a day or two. Other people, it sort of gradually comes on over a few weeks, but definitely a change. You know, your typical scenario is an otherwise, active, healthy 75-year-old who all of a sudden they seem to be struck by this. And the biggest thing is not so much the pain, but they describe functional debility. They have trouble reaching behind their back to putting on their shirt or getting up out of bed first thing in the morning just because of the severe stiffness. So functional limitations really severe. But don't forget, some people will have distal joint symptoms. Some series suggest up to 50%. And this would be places like the wrists and hands, knees occasionally, but never the ankles and the feet, okay? They will have oftentimes non-specific symptoms like fatigue, loss of appetite, weight loss, malaise, depression. Who wouldn't be depressed when you get these symptoms? And rarely fever. If you have fever, you can see that certainly with really aggressive PMR, but then I would think potentially an associated condition like temporal arteritis or giant cell arteritis. So there's a curious entity known as RS3PE, and it's an acronym which stands for remitting seronegative symmetrical synovitis with pitting edema. And it's kind of an interesting condition. This is one of my patients with it. They kind of have these boxing glove look to them hands, like a lot of diffuse swelling. And it's not just the joints, it's the tendons as well. So it almost looks edematous, okay? And the reason I put this up here is it may be on the spectrum of PMR. So some patients will have this, but they'll also have that shoulder and hip girdle aching. And it's almost like a periarthritis, hey, where they'll get joint and periarticular structures involved. Okay, let's do another polling question. So this is about investigations. Which of the following is false regarding investigating PMR? Rheumatoid factor and anti-CCP are negative. Ultrasound often shows fluid in the subacromial bursa, so the shoulders. Muscle biopsy shows increased perifascicular inflammatory cells, or increased CRP, which is false. Great. So the winner here is ultrasound shows fluid in the subacromial bursa, followed by rheumatoid tie of rheumatoid factor and CCP are negative, and muscle biopsy. Okay. So the correct answer is number 3. So muscle biopsy shows increased perifascicular inflammatory cells. Okay, so that is that's the correct answer, so it's false. So the muscle biopsy actually is normal in this condition. So number 1, yes, rheumatoid factor and CCP are negative in this condition. So it's a seronegative condition, unlike RA. Number 2, ultrasound often shows fluid in the subacromial bursa. This is true, okay? And we'll get into that a little bit more in a sec. Number 3 is false, so the correct answer. And number 4, of course, is true. And everybody's pretty much hooked into that. Yes, by many of these patients, almost all of them will have increased acute phase reactants. So let's move into investigating PMR. So I guess one of the clinical pearls take home here would be that PMR is not a disease of muscle. But you know what? When I was growing up and doing medical school and such, I thought it was as well, okay? Because where do people have pain? It's in their muscles, it's in their upper arms, it's in their thighs. But interestingly enough, muscle biopsies in this condition are normal, right? They really don't have muscle weakness, but they have muscle pain, and so it hurts to do things. We know the CK is normal, also pointing away from a muscle disease. I mean, there have been some research that has shown that the interstitial fluid, like the fluid around the cells, in the muscle tissue do show high levels of cytokines, but there isn't really primary pathology in the muscles. And we see that patients with PMR have high levels of interleukin-6. And that's a cytokine that's responsible for people to have flu-like symptoms when they have influenza, for example. So, when any of us have the flu, you get muscle aching, so that can drive some of the muscle pain as well. But that's not the whole story. So why do they have muscle pain? And the second point here is the reason why. Imaging. So when you image these people, they have periarticular inflammation and they have articular inflammation. So if you look at ultrasound, MRIs, PET scanning, you'll see that these patients will have fluid in their subacromial and subdeltoid bursa. They'll have tenosynovitis of their biceps tendons. And so when you have that, remember, if you've got, let's say, a rotator cuff disease or rotator cuff tendonitis, where do patients feel the pain? It's usually in their upper arm. So if you can imagine, if you've got an inflammatory condition affecting the shoulder joints and the bursa around the shoulder, you're going to have pain in the upper arm. And that's why they have the upper arm pain. We also have these little bursa that sit on the spinous processes in the back of our vertebral bodies and our C-spine. And so those get inflamed. Around the hips, there'll be fluid in the trochanteric bursa. There'll be fluid in the iliopsoas muscle and the ischiogluteal bursa and hamstring tendon insertion sites. So all of those areas of inflammation give you that thigh type of pain. And in the actual joints, you get swelling or fluid rather in the hip joints and the shoulder joints themselves. So really what's felt to be the cause of the pain is this arthritis and periarthritis that's in those proximal structures and referred pain. So what about the investigations? So we know that acute phase reactants are almost always elevated. So that's your CRP or ESR. But you'll also could have, but not always, non-specific lab markers of inflammation. So you might have anemia. So we call it anemia of inflammation. You could have leukocytosis, particularly in neutrophilia. You may have an elevated platelet count, again, as a marker of inflammation. I would typically, if someone was presenting with these symptoms, probably do some other tests to help rule out other conditions that can mimic PMR. You wouldn't necessarily do all of these tests, but rheumatoid factor and anti-CCP. So these are blood tests for rheumatoid arthritis. They are typically negative in PMR. And so, and we'll talk about differential diagnosis in a second, but rheumatoid arthritis certainly would be something I would be thinking about if someone presented with these symptoms. So negative tests there would help rule out rheumatoid arthritis. If you had a younger individual, you may consider SLE, lupus, in the differential diagnosis. A negative ANA rules out lupus. A positive ANA you don't know. So it may be appropriate in some individuals to get an ANA. An ANCA is a blood test for vasculitis, known as ANCA-associated vasculitis. So may be appropriate, maybe not in everybody, but in some people I might order an ANCA. But of course, older people have other things potentially wrong with them, like malignancy, multiple myeloma, thyroid disease. So SPEP, serum protein electrophoresis, might be worthwhile getting, chest x-ray, checking their thyroid. Hypothyroidism certainly can be a mimicker of PMR. And then if they've got fever, of course, appropriate cultures may be appropriate. But I would say the most useful diagnostic test, and this is another clinical pearl, would be a test dose of low-dose prednisone and how they do with that. Because most folks will respond to low-dose prednisone almost immediately and completely, okay? So that would be important to remember. But more on that in a second. As you can imagine, though, PMR is a challenging diagnosis because musculoskeletal symptoms are almost universally present in the age group that we're talking about here. Over 50, hey, I know we all have our aches and pains, right? So you're dealing with people that have concomitant osteoarthritis, regional pain syndromes like rotator cuff disease, for example. So it can be really, really tough. We know the PMR symptoms, many are quite non-specific, malaise, for example. We know that there's many conditions that can mimic PMR. And you know what? There's no specific diagnostic test. There's no test for PMR. It's based on a good history. And so again, a challenge. And I would say the other challenge, and we'll get to this in a little bit, is this association with giant cell arteritis, vasculitis, and how do we determine if that's present? So I think we need to consider the differential diagnosis in this condition because there are mimickers or other things that we might think about. And I would put rheumatoid arthritis number one. So again, if we've got a patient with that change in symptoms, they're doing really well, and then all of a sudden they've got painful aching shoulders, may have some hand swelling, which she said can go along with it. Could this PMR be rheumatoid arthritis? Absolutely. There's really nothing much different between them in presentation, especially in the older population where we know there may be more common shoulder involvement in our older patients with rheumatoid arthritis. So how can we know it's not RA? Sometimes early on you don't know, but one of the key differences, which I alluded to in that second polling question, is there's not involvement of the feet. So if you've got someone that kind of presents more with hands and feet, maybe shoulder involvement, I would think more rheumatoid arthritis. Remember, rheumatoid arthritis often, although not always, can be rheumatoid factor anti-CCP positive, so that can be a distinguisher. And then how they respond to prednisone. Patients with PMR are very sensitive to prednisone. They do get better with prednisone, while patients with RA get better with prednisone, they don't in the same way. They don't have that really exquisite response. So that would be kind of your big distinguishing feature as well. What about other features? Other things would be disease like osteoarthritis. Again, that would be more of a chronic type situation, not a big acute change. Maybe more asymmetrical. Let's say if they've got hip OA, would be more on the one side. What about regional pain syndromes? Almost universal that patients over the age of 50, 60 are going to have some chronic rotator cuff disease. So that can be sometimes difficult to distinguish. What about spondyloarthritis, ankylosing spondylitis? Well, they typically present a little bit younger, but can be different. Of course, spondyloarthritis will have X-ray changes of that, such as sacroiliitis on SI joint imaging. What about myositis? Myositis, they typically present with proximal muscle weakness, not as much pain, and they'll have a high CK. What about drug-induced statins? Statins can give you a high CK, but maybe not always, maybe just myalgia, so that can be confusing. I saw a case recently of an immune checkpoint inhibitor prescribed for cancer, so pembrolizumab, which gave a PMR type condition as a side effect. So that's been now well described. Thyroid disease, as I mentioned before, hypothyroidism, hyperparathyroidism, like hypercalcemia, like people with a high calcium level can have bone pain. Fibromyalgia, you guys are experts in that after your excellent talk with Dr. Bichet on fibromyalgia. But again, fibromyalgia more sort of a chronic course, typically presents in a younger person, more widespread, both proximal and distal symptoms, so a little bit different. Older population, you always have to think of other types of malignancy. I had a patient with myelodysplastic syndrome that presented with PMR, for example, and they may be less common, but certainly in the differential might be infection if they're presenting with fever. So when should you refer a patient? So with PMR. So I would say that anybody with PMR, it's not wrong to refer them to rheumatology. I would say, though, it's also not wrong to manage this patient yourself, but it really depends on your comfort level and experience. I would say a straightforward PMR patient certainly is in the purview of primary care. But I would say that if you have a patient that does not respond to prednisone in a typical fashion, that would be maybe somebody to refer. If they've got prominent peripheral symptoms, so hands, for example, you'd wonder, gee, maybe it's rheumatoid arthritis, definitely refer. Your sicker patient with fever, weight loss might be somebody to refer. If you have somebody and they're doing okay and then they relapse, what's the role for steroid sparing drugs, etc. And then definitely anybody that has giant cell arteritis, you need to refer them because we're talking about big gun medications in some of those individuals. So what about accessing rheumatology? So this has become really, really problematic. I've been in practice in Edmonton for close to 30 years. We always prided ourselves in having really good access to rheumatology. But what I've seen lately is we've had 3 rheumatologists retire in the last couple of years. We're seeing just population increase. We're seeing sicker patients. And so many rheumatologists won't see non-inflammatory disease now, like OA. But remember, PMR, I don't think I've heard of anybody refusing a PMR consultation. So we love to see inflammatory disease. When I'm triaging, so literally every day I have referral letters sitting on my computer screen, and I'm trying to figure out, this one's 3 months, this one's 2 weeks, this one's 6 months. It's really hard because I'm not seeing the patient. So a good referral letter really, really helps me in figuring out when I'm going to see these patients. If you are suspicious of PMR, sometimes I'll write back and I'll just say, hey, try some prednisone, see how they respond, right? And also don't hesitate to call. I have a cohort of GPs that seem to call, and I really enjoy that because we can get something in place, in the short term and see how they do, right? While they're maybe waiting for an appointment spot. So that would be kind of the tips I would say in sort of accessing rheumatology. I'd like to say if all else fails, please pick up the phone because that's probably your most powerful intervention. So we're going to move on and talk about treatment, the treatment overview, initial management, relapsing disease, and a little bit on steroid-sparing drugs. So we're going to have another polling question. So what would be a reasonable starting dose of prednisone for PMR? 7.5 milligrams per day, 15 milligrams per day, 25 milligrams per day, or 40 milligrams per day. So starting dose. Yeah, 15 milligrams, the most common, 44%, and that would be the correct answer. The other answers are not necessarily incorrect, but I would say 40 milligrams is incorrect. We wouldn't use that high of a dose. The smaller doses, there may be a role, so we'll talk about that. Okay, so in terms of initial management of PMR, the primary goal really is to relieve symptoms. Remember, these patients, they're functionally debilitated. They're not dressing themselves, and it's going to lead to all sorts of other problems. So we want to relieve symptoms. But this is a surprisingly poorly studied disease, and there's very little good clinical trial evidence on our best way to manage these patients. But prednisone is definitely in the mix here. So all patients should be placed on prednisone, and it's the first line treatment, okay? Treatment does not seem to improve prognosis, so it doesn't really, I would say, change necessarily the natural course of the disease, and it doesn't prevent GCA, giant cell arteritis, but nonetheless still important, okay? So you'll want to see that really good, quick response. These are patients typically where I would give them a dose of prednisone, such as 15 milligrams per day, ask them to call me back within a week, let me know, and many are just like amazed. sometimes that evening they're starting to feel better. And that's the response you want to see. That's the kind of typical response. Usually we keep prednisone going for 1 to 2 years, and then it's sort of tapered over that time. But as we'll learn, relapses are common. So we start at 15 milligrams per day. There's a range. If you have somebody that maybe older, frail, thin, maybe steroid risk factors like they're a diabetic already, that type of thing, you may want to start on a lower dose. Larger individuals, higher inflammatory burden, let's see, sicker patients may require a higher starting dose. Nonetheless, I start almost everybody in 15, and then if they have sort of a partial response, I may go up to 25. You would never go up to higher than that, because if you're needing more than that, they probably don't have PMR, okay? They probably have something else going on with them. Sometimes people will have a wearing off effect, like they'll feel great the first part of the day, then their disease sort of comes back end of day. You may want to do BID dosing, like 7.5 milligrams twice a day, for example. Interestingly, NSAIDs don't seem to work. They don't seem to give much benefit at all. So what I do with prednisone, this is kind of my scheme, and I think most rheumatologists follow something quite similar. I start them off on 15 milligrams, give them a test dose per week. If they have a decent response, we keep that going for a month. Then we cut it by half a tablet to 12.5 milligrams for a month, 10 milligrams for a month. Then we switch to the 1 milligram tablets, and then we reduce it by 1 milligram each month until they're off of it. So if they're successful with this tapering routine, they're off within about a year. Some studies have shown that the mean sort of duration of prednisone is about 18 months, but some people can be off quicker. So this would be kind of a standard approach. If I have somebody that, let's say they have like a super robust response, like they're just like, everything's good, I might taper them a little bit faster at the beginning. I might go 15 for 2 weeks and then 12.5 for 2 weeks and then maybe 10 for a month, something like that. But as you get down to those lower doses, you have to go slowly. Like one of the biggest mistakes that I see in patients that are referred to me with that have already been managed with their PMR is just tapering that prednisone way too fast. Because what happens is they flare, you go up again, you're going up and down, and that's not great either. You have to be mindful of comorbidities with steroids. So steroids are nasty drugs. We think about osteoporosis. If you're on more than 7.5 milligrams of prednisone for 3 months, osteoporosis treatment is actually recommended. Bisphosphonates typically. Got to monitor and look out for diabetes, cardiovascular disease, hypertension, dyslipidemia. So just be mindful of all of this. So what about relapsing disease? I used to be very pedantic when I first started practice. Oh, everybody gets better. 18 months, you should be off of steroids. If it's not, like you're atypical. But there's actually emerging evidence, and my own clinical experience suggests that relapses are incredibly common. So if you look at patients still, about half of patients will have at least one relapse in the first year. And if you look at 2 years, about a half patients are still on steroids. And at 5 years, a quarter of people are still on steroids. I mean, some of this might be clinical inertia, like they're just not actively being tapered off their prednisone, but other patients, they just truly are relapsing. So we have to know, is it a relapse or not, right? So I find it super common for patients to have a bit of arthralgia, myalgia when they're tapering their steroid. And sometimes I'll just tell them to kind of put up with that for the first week or two. And then if it's truly, worse, then they may go back up to their previous effective dose. But the problem is prednisone is probably masking their chronic rotator cuff disease. It's probably masking their osteoarthritis to some extent. So you just have to be mindful of that. But definitely, if they have, especially with a concomitant rise in their CRP, I would be worried about relapse in their disease. We know some people will even get kind of fibromyalgia-like symptoms with PMR tapering. I've seen that not infrequently as well. You just have to be mindful that that wouldn't be managed by increasing the steroid. So how do you manage flares? And this is entirely what I do because there's really no data. Usually what I do is I advise patients to go back up to their previously effective dose of steroid, try it again for a month, and then taper again, usually going down by the 1 milligram. If there's that persistent sticking point, if they can go down to 5, but they can't go to 4, I might park them at 5 milligrams for a couple of months rather than a month, maybe even 3 months, and then try tapering by 1 milligram a month. If their sticking point is high, like they can't go below 7 milligrams, I consider steroid sparing drugs. Other patients, I just admit defeat. If I can't get them below 2 or 3 milligrams, you know what? Morbidity is pretty low at those doses. So we may just say, hey, this is the way it's going to be. And actually, I just saw one patient this morning. She's on 3 milligrams. She's had PMR since 2015. 3 milligrams. She's happy. I've tried tapering her off so many times, and she just is miserable. And so we're just managing with 3 milligrams. So what about steroid-sparing drugs? I would say this is more for your information than anything, because you're not going to manage these patients that are on steroid-sparing drugs, because this is the job of the rheumatologist. But it's not defined. Most patients probably don't need steroid-sparing drugs, unlike, let's say, diseases like rheumatoid arthritis, where we use DMARDs and biologics. We don't. Most patients with PMR are not on these drugs. But of course, if they can't get down on their steroid, like I said, or if they have lots of prednisone side effects, like the case that I presented, then we want to look at steroid sparing type drugs. So second last polling question. This is a hard question, okay, but I'll just put it up here for interest. Which drug has not been shown to be effective in treating PMR? Number 1, infliximab, which is Remicade, so a drug used to treat RA. Number 2, tocilizumab, Actemra, another, it's an IL-6 inhibitor. Number 3, methotrexate. Number 4, sarilumab, another IL-6 inhibitor. So which drug has not been shown to be effective? It's a hard question. I probably shouldn't have, it's not fair to put that in there, but it sort of sets the stage for the last couple of slides here. Actually, you guys got it right. It's good. 39% Remicade infliximab. That's correct. So anti-TNF drugs, surprisingly, so they're a godsend for rheumatoid arthritis, but anti-TNF drugs, Remicade, Enbrel, Humira, they do not work for PMR. All the other 3 there have been shown to have some effectiveness in dealing with PMR. So good job. Methotrexate, basically suffice to say there's evidence, but it's weak evidence. So we'll consider it's my first line sort of steroid sparing drug in those tough patients. What about other sort of medications? Just lack of evidence. Hydroxychloroquine, Plaquenil, there are no studies. But if I've got somebody with swollen hands, looks kind of like that RS3PE, for example, I'll give it a go. It can work. Other sort of DMARD drugs, so to speak, for rheumatoid arthritis don't really work. Leflunomide, immunosuppressants haven't been studied. Imuran, for example, there's no data. What about biologics? Suffice to say, like I say, the anti-TNF drugs, like we said, they don't work. Your Remicade, Enbrel, Humira. Where there seems to be effectiveness is in the IL-6 inhibitors, tocilizumab and sarilumab. And then there was kind of a dose-finding study, rituximab, that showed it to be effective, a B-cell inhibitor. But again, the role for that drug is a little bit, we don't know yet, not enough data. I put up sarilumab because it's approved in the USA by the FDA for PMR, because there was actually a New England Journal of Medicine study in 2023 that showed it to be effective. But the role of this drug, unfortunately, is not well defined. But I do have 2 patients on it. We have it in Canada for rheumatoid arthritis, and so it can be used. And just wanted to put it up here that it was approved by the FDA. So just in the last kind of minute or so, I just wanted to just talk about giant cell arteritis. Um, I would say that from a primary care level, you just have to recognize it's an associated disease. And you basically have to ask them all your PMR questions, new or different headache, visual change, scalp tenderness, jaw claudication. So, and patients need to be aware of these symptoms because although most patients with PMR do not get GCA, about 10% do. And of course, blindness is a terrible complication of that disease. So, and we would diagnose GCA typically with a temporal artery biopsy, but ultrasound, and this is stuff that we would worry about. I don't think from a primary care level you necessarily need to worry about it. You could phone for advice. We have Dr. Mary Stevens. She's a general surgeon at the U of A who's been doing our temporal artery biopsies quite quickly, within usually a couple of weeks. So we're very grateful for her service there. And then Dr. Nyo is a rheumatologist in St. Albert, who's the only one that has ultrasound experience in diagnosing temporal artery inflammation. So sometimes I'll get him to do it in a pinch as well. So back to the case. So this lady was stuck on really, really high doses of steroid. She had steroid morbidity. She didn't tolerate hydroxychloroquine, didn't tolerate methotrexate. So I actually got funding for sarilumab through the provincial STED program. So this is the short-term exceptional drug treatment program. And that was the first one that they had application they had gotten for that, and they approved it. I was quite happy with that. And so she's been on this drug, and she's been able to come down on her prednisone. She's now been on it over 6 months, and she's down. She's still above 10 milligrams, but she's slowly coming down, better than 25 when I saw her before. So I'm just going to finish my talk by just asking you the same polling question that I asked at the beginning. What is polymyalgia rheumatica? This is more for me to know, hey, did I do an okay job? So is it an autoimmune muscle disease? Number 2, is it an inflammatory arthritis affecting shoulders and hips? Number 3, a functional disorder with tenderness in the muscle tender points? Or is it a vasculitis of large blood vessels? Yeah, right on. So it is. So it's, I just want to emphasize again, it's an inflammatory arthritis, fluid in the shoulders and hips, periarticular structures. It's not a muscle disease. So number 1's incorrect. In 3 and 4, you never thought it was that in the first place. So that's great. And my last is just the conclusion. Again, most patients can be successfully treated with low-dose steroids. Most have a self-limiting course, but flares do occur and they're not rare. We sometimes use steroid-sparing drugs. That's my job to decide that, but just to let you know, they're aware, they're available for us without a lot of evidence. And there is some data for IL-6, so that's sarilumab, tocilizumab, as working in some of our patients. So on that note, we've got a few minutes for questions.
Fantastic. And I know, I'm sure the talk was completely clear. I think we had people joining Dale over the talk. So I know myself, I would have initially wondered about muscles. So that was a great teaching point.
Yeah.
Peter's asking a question about the role of ASA in giant cell arteritis and how long should ASA be used?
ASA, yeah, that's a great question. A little bit controversial. So giant cell arteritis, it's a large vessel vasculitis, and there's a study that came out of Mayo suggesting reduced relapses of giant cell arteritis on patients taking kind of our cardioprotecting doses of ASA. We know, but that's controversial, so not everybody does it. We know patients with vasculitis, and actually PMR, do have increased cardiovascular risk because of the inflammatory burden. So there may be, depending on their sort of total risk profile, there may be a role for ASA. As a treatment for GCA, we wouldn't use ASA. It's high doses of steroids, and we're using tocilizumab, IL-6 inhibitor for that disease. Yeah.
Okay, no, that's awesome. And so lots of practical tips, but I just wanted to go back and folks, just to remind you, if you've got questions for Dale, please stick them into the Q&A. But I did want to go back, Dale, just on the suggestions around workup. In terms of labs, just if we could clarify that one a little bit. So you said rheumatoid factor and anti-CCP should be negative, but excuse my ignorance, but I thought sometimes RF could be elevated in the general population.
Yeah.
So do you want to just clarify that one?
Yeah, great question. Very astute. Yeah, so in this patient population greater than 50, upwards of 10% of patients can be rheumatoid factor positive, but they are typically really low titer. So our cutoff in our lab's like 20, and you'll see like a 30 or a 40. Those are really, really, I think of them as being negative, but they're positive. So you'll see that. I would say that, generally speaking, if you have a positive rheumatoid factor, especially CCP is more specific for RA, I would think about RA. But I could say it's so challenging, Denise, because even in this population, you can get seronegative rheumatoid arthritis. There's a great mentor of mine who said to me, if someone is seronegative, every time you're seeing them in follow-up, you're revisiting the diagnosis. Do I have the right diagnosis? And I've had PMR patients where down the road, like I taper their prednisone, and they blow up synovitis everywhere, hands and feet, and they ended up having RA. So sometimes you just don't know.
Okay, so it can be a bit of a conundrum. So
Exactly.
reasons to phone.
Yeah.
Karen has a question. Thanks, Karen. She says a patient who was treated for PMR 2 years ago is complaining again of myalgias in the shoulder and hip area, similar to when she had PMR, but much less severe. Her CRP is normal. Could this be a relapse?
Yeah, it could be. A small subset of patients with this disease can have normal inflammatory markers. And I also it's really helpful to look at the past CRPs. So sometimes we'll just see a CRP of like 5. It's not flagged. We think about it's normal, but you look at when it was normal, their CRPs are always less than 0.5, less than 5 or less than 0.5. And so sometimes their CRPs, when they're 5, that's actually quite high for them, versus 0.1 or 0.4. So sometimes even they might have a very mild rise, and it just means their inflammatory burden's not like it was. So if they've got similar symptoms, I'd almost test dose them back with prednisone again, but maybe not as high, like maybe 10 milligrams, just to see how they do, and you could taper it fairly quickly, maybe. Yeah.
And would there be a role there just as a follow-up for some ultrasound for that patient?
Yeah, that's controversial. The problem with ultrasound, as I mentioned, they often will have fluid and so on. Problem in this population, most of them don't have normal rotator cuffs and subacromial bursa to begin with, so you can't tell. Like, because the differential maybe in someone with shoulder pain is, do they have just subacromial bursitis, right? And they can look identical to PMR with a little bit of fluid. I would say your one value is like if they come on symmetrically, it's more likely to be PMR versus one side versus another. But ultrasound, sometimes I find it's just more confusing than helpful.
Okay, great. And Fausia has a question around what's the risk of cancer with biologics? She says, my patient with PMR and later diagnosed with GCA got treated for a year, but recently was diagnosed with lung cancer, squamous cell. I just wanted to know, could this be related to biologics?
So she would have been put on tocilizumab. It's very unlikely. There's these drugs have been out a long time. The anti-TNFs came out in about 2000, so we've got 24 years of prescribing history, huge registries. We don't see more solid tumors like lung, ovarian, breast. There was a question about hematologic malignancies like lymphoma. That's probably not true. The problem is many of these inflammatory diseases like RA have higher rates of lymphoma anyway, so it can be tough to know. But for a lung cancer, I would would be pretty convincing it has nothing to do with her biologic in that case.
Great. And then Tiffany is asking, um, and she mentioned she just missed the first part of the presentation. So I was wondering if you could review just a little bit about that prednisone taper again.
Yeah.
Uh,
Yeah, just quickly. So it's typically I start with 15 milligrams as a test dose. If they have a robust response, you're confident with the diagnosis, you do 15 milligrams for a month, 12 and a half for a month, 10 for a month. Then you switch them to the fives and ones to go to 9 milligrams for a month, 8, 7, 6, 5, 4, 3, 2, 1, until you're off of it in 1 monthly intervals. With relapse, I go up to the previously effective dose for a month and then taper it again.
And also, just for those who joined, FYI, in a week or so, you should get a copy of the audio of the presentation as well as the Pearls document. And Dale's done a great job of sort of highlighting some pearls today. Um, folks, there's Donna's got a question here. She just saw an elderly man who fits your description of the RS3PE. She states, I've never seen this board, nor have I. Is this a condition for which we should be referring to rheumatology?
Yeah, absolutely. Yeah. Yeah, because this could be RA. What makes RS3PE different is that typically are seronegative, or whatever that means. So RF-CCP negative. They also respond to steroid very nicely, but they also respond to hydroxychloroquine very nicely. So a very mild drug. And the part of the R, one of the R's in RS3 is remitting, right? So remitting, seronegative. So they will typically get better, but they're miserable with it. They can't do anything with their hands, as you can imagine. So great case. Like sometimes we'll do ultrasound, although it's pretty apparent, like they're swollen up. You probably ultrasounds isn't going to add very much. So yeah, great. If you put that in the referral letter, I would notice, hey, RSVP, I want to see that person for sure.
Okay, that's super. And so just folks, go ahead and pop your questions in the last few minutes, but just wanted to ask, so I was just flipping through the Alberta referral pathways that are starting to be formed, and it looks like there was a GCA one, but it doesn't look like there's one on PMR. Is there like some ongoing work to try to, put some of this into the pathways bucket?
It's a great question. I don't believe there is at this stage. I mean, maybe down the road. The problem with pathways is it would mean that there's one central sort of intake for all rheumatic disease, and that's not the case in Edmonton. So if you want to refer to Sholter, it's directly to Sholter. If it's Bichet, it's Bichet. The U of A have their own group, but you refer to collectively the U of A. So I try to, I mean, I think pathways are okay, but the issue really, I guess the reality we're facing is we're still relying on that really good referral letter of what you suspect is going on.
So, and I was just flipping and I realized, so we have a thing that you may or may not be aware of called Connect MD out of Edmonton North PCN, which is a way for docs to put a text in and then have a chat with a consultant within a few days. And I was just having a look, and it looks like rheumatology has just the specialist telephone advice through the Connect MD program, just so everybody knows. There's no resources in that website yet for us, but there is a telephone number there. So that's a way, folks, if you have questions like that case that we were just hearing about from Linda, that you could, connect, or sorry, from Donna, that you could connect in with rheumatology. Are there other ways, Dale, that people could, connect?
Yeah,
If they have?
I would say that just phone, like don't be afraid to phone. Like so there is either you could, if you're not sure who to phone, Royal Alec switchboard to talk to the rheumatologist on call. So there's always a rheumatologist on call for community. And U of A also has a group, so you can call U of A as well. So we're separate, but nonetheless, that's the one way. Outside of town, there's Rapid North, which is a way sometimes we see consults through. So that's something out. I believe that's available outside of Edmonton. I'm not 100% sure how you access that, but that would be. But I would say, don't hesitate to pick up the phone. Certainly it's good.
Okay, awesome.
Yeah.
Well, I'm mindful that clinic starts in 1 minute. So super rounds, Dr. Sholter. Thanks a million on behalf of everybody. Did I miss a question? Oh, no, Donna says thanks.
Ah, good, good. No, I appreciate the invite. It
Look,
was,
saying
I
thanks.
was really had a lot of fun. So thank you.
So please, folks, please do the eval form. Just take a quick minute and do that for us. Be fantastic, so that we can take your feedback, continue to improve. We already are chatting with the colleagues in rheumatology about more events because this is just such a hot area for all of us, especially with all these new meds. And just really appreciate everyone coming out, and really appreciate Dr. Sholter you taking time to do this. It's really great. Thank you so much.
Yes, thank you. All the best.
Yeah, thanks. Take care.
I know.